All right, guys, welcome back to Clinical Anatomy for PA students. Today we'll begin our discussion of the lower extremity. Coxa vara and coxa valga have to do with the femoral angle of inclination, or the angle, the bend that's present in the proximal femur. The proximal femur is bent with the head and neck flexed inward or anteromedially compared to the shaft of the femur. Real quick, just when you look at these numbers right here, this 45, there's a 1 that's cut off there. It's supposed to be 145 degrees. So looking at the femur, you have the long shaft of the femur, okay, which comes in along the vertical axis. And then if you draw another line that goes through the neck of the femur, through the neck and head of the femur like this, and then look at the angle between the two, that's the angle of inclination. Because again, the shaft of the femur comes up relatively vertically, and then where the femur is attaching to the pelvis, it takes a sharp turn medially as it goes in, and the head then meets with the acetabulum. This angle of inclination of the femur varies with age, with sex, and then development of the femur, obviously. When we look at the way that it varies with age, the angle starts relatively large. It starts out about 150, 145 degrees in children, and then the angle gets smaller as we age. And then in adulthood, the angle will typically get down to about 120 degrees. Any pathological process that affects development of the femur can affect the angle of inclination of the femur. So for example, things like rickets that are associated with a weakening of the bones and a bowing of the bones can also affect the angle of inclination. The angle of inclination, or the femur is shaped like this in order to provide greater mobility at the hip. The hip is a highly movable joint. There's a ton of mobility present. And this angle of inclination is one of the things that contributes to that. However, the angle of inclination does put great stress on the neck of the femur, which is why when the femur is fractured, it's typically fractured at the neck because of the great stress that's put there. Just looking at the femur again, the shaft is the long region of the femur, and then the head is just the rounded part, right, that's going to meet up with the acetabulum, the cup-like opening on the pelvis. When we look at the neck of the femur, there's an anatomical neck and surgical neck. The anatomical neck is just where it starts to thin out underneath the head, and then the surgical neck is the actual thinnest point that's present there. So the femoral angle of inclination, again, is just the angle between the axis that goes along the shaft of the femur and the axis that goes through the neck and head of the femur. And that should be around 120 and 25 degrees in adults. Coxa vara and coxa valga are pathologies that are associated with an abnormal angle of inclination. Coxa vara is when the angle of inclination is decreased. So there's less of an angle of inclination, which you see right here. So typically, this would come at an angle that's less horizontal. Okay, so the proximal end of the femur would be going more superiorly. It would rise more as it goes in to form the hip joint. So instead, the angle is decreased, and that can alter the stance of the individual, and it tends to shift the femur inward, right, or more medially as it descends, and results in what we would call knock knees, right, where the knees go in and meet more at the middle. So this is a normal stance. Okay. You can see the angle of inclination right here. And the femur does go in some as it heads toward the knee joint, and then the tibia and fibula straighten out more as they head down towards the ankle. This knock knees is what occurs with coxa. Again, there's less of an angle right here, and as a result, the femur comes in very close to the midline at the knee, and then the tibia and fibula then shift laterally. Distally, they head out laterally. Coxa valga is the opposite. Coxa valga is when the angle of inclination of the femur is increased. And this is what you see right here. Right? So now there's less of a bend. The proximal end of the femur is more vertical and less horizontal. That results in what we'll call, or colloquially we would call bow-legged. And that's right over here. So here you see that the legs are more straight. So the femur typically does come in slightly medially as it descends. Instead, the femur is coming straight down, right? And then the tibia and fibula actually come in towards the midline a little bit, and it gives that bow-legged approach. That bow-legged appearance where the legs look like they're bowed. The femur is a really large, strong bone. However, because of the angle of inclination, because of the way that the femur is structured at the hip joint, the neck of the femur is a common fracture site. That's the most common site that the femur gets fractured at, is at the neck. This is especially common, or most common, secondary to osteoporosis in women. With osteoporosis, there's a loss of bone mass, so a loss of bone strength. And in severe osteoporosis, even a little stumble, a little fall, a low impact fall can fracture the neck of the femur. The neck of the femur, or really the proximal end of the femur, can be fractured in numerous different locations. We'll look at those on the next slide. The shaft of the femur is a really dense area of bone. It's made up of thick, compact bone, so it's very strong. However, direct force or direct impact that's very hard can fracture the shaft of the femur. So for example, in a car accident where there are really large forces applied directly to the femur, the shaft can be broken. Here you see all different types of fractures of the shaft. A transverse fracture obviously is just going across in a transverse plane. A linear fracture is going in a vertical plane. Oblique can be non-displaced or displaced. Oblique is obviously just an abnormal angle, so it's not horizontal or vertical, it's a diagonal angle. In non-displaced, you see the bones are still in the appropriate position. In displaced, the bones have been moved. They're no longer lined up appropriately. Spiral fracture, spiraling around. A green stick fracture on just the one side here. And then comminuted fracture is when, remember, the bone is broken into numerous pieces. So there are multiple small little fractures there that have broken the bone up into multiple little pieces. So here you guys see the different fractures that can occur in the proximal end of the femur. Again, right where it would form a hip joint or a joint with the pelvis. A capital fracture is when just the cap of the head, right, or just the top of the head is broken off, which you see right here. Remember, the head of the femur is this big rounded portion, right, where it fits into the acetabulum, where it forms a joint with the pelvis. So think of it, a cap, right, is like you put it on your head, the very top of your head. So a capital fracture is when you fracture off just the very top of the head. Subcapital is just below that, right? So subcapital is where the fracture is a little bit lower and you're taking off or fracturing more of the head. Transcervical. Cervical refers to the neck, right? The cervical region or cervical vertebrae. So transcervical is like saying across the neck. And this is what you see here. Remember, this is the surgical neck of the femur, is where it gets really thin here, the thinnest, weakest point in the proximal femur. So a break directly through that surgical neck is transcervical. Intertrochanteric is a fracture between the trochanters. So again, looking at the proximal femur, there are two predominant or very obvious processes that you guys should be familiar with: the greater trochanter and the lesser trochanter. The greater trochanter is this large one over here. It's a large process that's located laterally. The lesser trochanter is the smaller process that's more inferior, and it's located medially. Okay, so greater trochanter, lesser trochanter. A fracture that goes through those trochanters is an intertrochanteric fracture. And then finally, subtrochanteric is just below the trochanters. So here you see the fracture going just inferior to the trochanters. Moving distally from the femur, we get down to the distal leg, or the lower leg, where the tibia and fibula are. So tibial and fibular fractures can occur individually or together. Both bones can be fractured, as you see right here. Tibial fractures most frequently occur at the union of the middle and inferior thirds of the bone. So if you break the bone into three, this area right here, where the middle and inferior thirds meet, happens to be the weakest point of the bone, and that's where it's most commonly fractured. The anterior tibia, tibia is very close to the surface, right? It's in the subcutaneous tissue. There's not very much tissue present between the anterior tibia and the skin, right, the outside. There's barely any fat present there. There's not any muscles there. There's very thin layer of tissue between the anterior tibia or protecting the anterior tibia. Because of that, this is the most common site of open or compound fractures. Remember, a compound fracture or open fracture is when the fractured bone opens the skin. Right? It penetrates through the skin and out to the outside, allowing blood to escape, which again you would see right here. Fibular fractures are common, or most common, just proximal to the lateral malleolus. So again, in lab, you should have looked at the bones and processes of parts of the bones. But if you look at the ankle here, the distalmost part of the tibia forms the medial malleolus, this bulge that sticks out on the inside of the ankle. The most distal part of the fibula forms the lateral malleolus, the bulge that sticks out on the lateral side of the ankle. So just proximal to the lateral malleolus, or just before the lateral malleolus, is a common site for fracture in the fibula. And you can see that in this picture on the bottom here. So the tibia is the larger medial bone, the fibula is the smaller lateral bone. The bulge at the very bottom of it is the lateral malleolus. So here you see that it's been fractured just proximal to that, just above that. So it literally like shears off or breaks off that lateral malleolus. This is typically associated with a fracture and dislocation of the ankle joint. So the ankle joint between the talus, right, the top of the tarsal bones, and then you see the tibia and the fibula forming that ankle joint. So when there's fracture and dislocation in the area, it shears off the lateral malleolus. This typically will occur when there's a fall that has excessive inversion of the foot. Inversion, remember, is where you turn the sole of the foot inward, right? So if the foot's normally flat, you can turn the sole of the foot out or in. Inversion is when you tip the foot inward. So excessive inversion can force the talus against the lateral malleolus and literally break it off. And that's again what you see here in the picture. So you can see, again, this is the top of the talus. And if the foot is inverted or turned in, the talus is going to get forced this way. And it's going to push off the lateral malleolus, or the very distal most part of that fibula. Bone grafts are just transplants of vascularized bone tissue from one part of the body to another part of the body. This can be used to replace or reform limbs that had congenital deformities, or restore integrity to limbs or areas of the body that were damaged by trauma, and then also to restore the integrity or replace bones that were excised or removed due to the presence of malignancy or cancer. The fibula in the distal leg is a common source of bone grafts. And the reason for this is that you can function perfectly normally after a section of the fibula is removed. Run, jump, hop around, perfectly fine without a section of the fibula. The reason for this is the fibula lacks weight-bearing function. The fibula is really there mostly for muscle attachment, so you're able to bear weight just fine while there's a part of the fibula that's been taken out. The bone, as well as the periosteum and nutrient artery, are all excised or removed to be transplanted. And the reason for this is that this allows the grafted bone to grow in the new site. The inner layer of the periosteum, remember, contains stem cells, right? It's got osteoprogenitor cells and osteoblasts that will lay down new bone in order to grow the bone in the transplanted site. Also, the blood vessels that are present eventually will grow and develop in order to restore the blood supply to that area of transplant. The epiphyseal plates, remember, are plates or little areas of cartilage that are present in bone towards the epiphyses, or towards the ends of bones. And these are what we would call growth plates. These are the areas where the long bones grow longer. If you think of a long bone, the diaphysis is the shaft, the metaphysis is just where we connect, and then the epiphysis is the widened end. And at the ends, there are little areas of cartilage, right? So it's bone tissue, and then the epiphyseal plate or the growth plate, cartilage, and then bone tissue again, right? And remember, the chondrocytes just lay down cartilage this direction, and then the osteoblasts or osteocytes lay down bone in this direction, right? And the bone continues to get pushed out. It continues to grow longer. And this happens until the bones stop growing longer, typically after puberty in late adolescence, early adulthood. So fractures that are near the epiphyseal plates are problematic when the epiphyseal plate is still active. So if the child is continuing to grow, the epiphyseal plate still has active cartilage growth, fractures in this area can disrupt the epiphyseal plate or the growth plate. So fractures near the epiphyseal plates are especially serious in children due to the possible interference with continued growth, or the possible stopping of continued lengthening of that affected bone. When we look at the tibia, the primary ossification center of the superior regions of the tibia appears shortly after birth, and then it remains active until about 16 to 18 years old. So the superior tibia, around where it forms the knee joint and where the tibial tuberosity is actively growing until 16 to 18 years old. The tibial tuberosity, which is, remember, the little bumpy protrusion on the superior and anterior area of the tibia, develops a primary ossification center at about 10. Sometimes a secondary ossification center will also show up around 12 years old. But this primary center that's present around the tibial tuberosity can be disrupted by a fracture in the area. And disruption of the epiphyseal plate at the tibial tuberosity can end up causing inflammation of the tuberosity that causes chronic recurrent pain all through adolescence while the plate is active. This is referred to as Osgood-Schlatter disease, and it is more frequently or more common in young athletes. Here we see a few things. We're just, again, looking at growth plate injuries in general. So looking at this, you have your shaft of the bone. Don't mind the silly cartoons. I try and avoid cartoons, but this kind of shows what we needed to see. So you see your shaft of the bone. The epiphysis, remember, is the widened end here. And then this little area is showing you where the epiphyseal plate is, or where the growth plate is. Right, so same thing here, like this little open area here that's not yet been ossified, that's cartilage, is showing you where the growth plate is. So fractures that impact growth plate or that injure growth plates can be classified as 1 through 5 classification, and this classification system is referred to as the Salter-Harris classification. So to remember the Salter-Harris classifications, right, type 1, 2, 3, 4, and 5, you can actually use an acronym, SALTER. It makes sense. SALTER for the Salter-Harris classification. So S-A-L-T and then E-R. So S, or type 1, is straight through, right? Or like straight across, rather. So this is when there's an injury that goes completely across the growth plate, right? So straight across is type 1. A type 2 growth plate injury is above the growth plate, right? So here you see the injury affects the growth plate from above. So A for above. L for lower. So a type 3 injury goes from the growth plate down lower or more distal. A type 4, T, is completely through, right? So it goes all the way through, above, through the growth plate, and below. And then ER is for erosion or crush. You could think R for crush. This is where literally the growth plate is crushed, right? There's forces applied from, or there's force coming at it from both sides, and the tissue, the cells are damaged just sheerly from crushing it. Okay, so SALTER for the Salter-Harris classification. Type 1 is straight, right? Goes straight across it. Type 2 is above. Type 3 is lower. Type 4 goes all the way through. And type 5 is a crushing or erosion injury. And again, the problem here is that interfering with the growth plate interferes with continued bone growth. There are numerous bones in the foot and ankle that can be broken. If you think about in each foot, you have 7 tarsal bones, 5 metatarsal bones, and then numerous phalanges, right? 3 phalanges in each toe, 2 in the big toe. So there are quite a few bones that can be broken. Calcaneal fractures are fractures of the calcaneus. The calcaneus is the tarsal bone here that forms the heel bone. Calcaneal fractures typically happen because of a fall. So a fall where you land on your heels. And these are typically comminuted fractures. Comminuted, again, remember, means broken into several pieces. Fractures of the talus. The talus, remember, is this tarsal bone right here that forms the actual ankle joint with the tibia. When the talus is fractured, it most frequently occurs at the talar neck, which is the fracture you see in this picture. So this fracture right here is a fracture through the talar neck. This occurs due to severe dorsiflexion of the foot. Dorsiflexion, like if this is the foot, right, the toes, is when the toes go up, right? So you flex the dorsal side of your foot up. This happens, for example, in car accidents. So like a head-on collision when someone's pushing on the brakes really hardly, and then there's a big impact, and the foot gets overly dorsiflexed. So the foot comes back up this way, and that can fracture the talar neck or the neck of the talus. Metatarsal and phalangeal fractures are common in endurance athletes where there's just constant repeated stress on the feet, like marathon runners, for example. Also, when a heavy object falls directly on the foot, that can break the metatarsal bones or the phalanges. The phalanges are also broken frequently from kicking things, so accidentally like walking and kicking something, and that's most frequently the smaller, so the fifth, the phalanges of the fifth toe, the pinky toe. Female dancers or ballet dancers that use demi-point technique, so that use point shoes, right, like ballet shoes that have a little wooden block on the tip with the toes, commonly fracture the fifth metatarsal. The fifth metatarsal is the metatarsal of the pinky side of the toe or the lateral side of the foot. The reason for this is when they're up on the toes and then fall and the foot rolls, right? So you fall onto the pinky side of the foot and it rolls, and that fractures the fifth metatarsal, typically proximally or closest to the tarsal bones. This is referred to as dancer's fracture because of how common it is in ballerinas. There are quite a few points on the lower limbs that are either easy to visualize or easy to palpate, or both. The iliac crest and anterior superior iliac spine are easy to palpate. The iliac crest is the highest point on the lateral sides of the pelvis. If you follow the iliac crest around anteriorly, the most anterior point of the iliac crest is the anterior superior iliac spine. The anterior superior iliac spine is used as the superiormost point when measuring the legs. So to get a measurement for the length of the leg, you go to the iliac crest, follow the iliac crest around anteriorly, and the anteriormost point is the anterior superior iliac spine. You measure from the ASIS down to the medial malleolus on the same side. The medial malleolus is the ankle bulge on the inside of the leg, which is, remember, the inferior part of the tibia. So from the ASIS to the medial malleolus gives us an accurate measurement of leg length. The posterior superior iliac spine is not easily palpable, but it's easy to find. The posterior superior iliac spine is just the posterior-most portion of the iliac crest. Again, while we can't palpate it, you can find its location by looking for the little skin dimples that are present on the lower back in the sacral region. The skin dimples are typically about 4 centimeters lateral to the midline at the sacroiliac joint. So you can typically see a little flattened area. You see like the spinous processes go down the spine, and then the flattened triangle where the sacrum is. And on either side of that, there's little dimples. So it's bilaterally on each side. There are little tiny dimples, and those mark where the posterior superior iliac spines are located. The gluteal fold is the little crease underneath on either side of the gluteal region. And the gluteal fold marks the inferiormost border of the gluteus maximus muscle. The greater trochanter is easily palpable. The greater trochanter is a kind of large lateral process on the proximal femur, the top of the femur. The greater trochanter, again, it's on the lateral hip. It's easy to palpate. If you can't figure out exactly what structure it is, lay on your side on a hard surface. So if you lay on the floor or lay on something hard on your side, that point in your hip that hurts, that's pressing into the ground, that's where the greater trochanter is. The lesser trochanter is not located laterally, right? The lesser trochanter is located medially, so that's harder to get to. Going distally on the femur, the distal end of the femur where we form a joint with the tibia, you can palpate the medial and lateral epicondyles. The medial and lateral epicondyles can be palpated by finding the patella, which the patellar kneecap it's really easy to palpate the medial and lateral borders of the patella. And then moving out laterally from the patella, you'll feel the medial and lateral epicondyles of the femur. The tibial tuberosity is easily palpable about 5 centimeters below the apex of the patella. So the tibia kind of comes like this, right? And the tibial tuberosity is like right here. And then it forms, there's your knee. And then of course over the top of this would be the patella. And the patella, the kneecap, is easily palpable. When the leg is relaxed, you can kind of manipulate it or move it around a little bit. So if you just follow the medial and lateral borders of the patella inferiorly, the apex of the patella is the inferiormost point right here. So if you just move down about 5 centimeters, you'll feel an anterior bulge that kind of sticks out anteriorly a little bit on the tibia. That's the tibial tuberosity. Now, the tibial tuberosity is connected to the patella via the patellar ligament. So the softness right here, right, if you find the patella and then just start to palpate downward, you'll feel it's a little bit softer and mushier, and then you get to the really hard tibial tuberosity. That softness that you feel in between the tibial tuberosity and the patella is the patellar ligament. The medial and lateral condyles of the tibia can also be palpated, right? So the medial and lateral condyles of the tibia, those can be palpated. They're located on the proximal tibia, so on the top of the tibia, and kind of the anterior side or front of the leg. They're located just on either side of the patellar ligament. So if you palpate the patellar ligament here in the middle and then just palpate on either side of it, you'll feel kind of like little rounded masses of bone. And those are the medial and lateral condyles of the tibia. The fibula, the head of the fibula is also palpable in the knee region. The fibula is located it's located laterally, but it's also a little bit behind the tibia. So like it would be kind of out back here. The head of the fibula is at about the level of the tibial tuberosity. So if you found the tibial tuberosity and then just move out laterally, so towards the outside of the leg, and you'll just head, so towards the outside of the leg, it's on the lateral side at the very back. So you don't quite go to the back of the knee. but right before you would turn to the back of the knee, you'll feel a rounded bulge of bone, and that's the head of the fibula. In a relatively thin person, you can see it, but it's very easily palpable if you can visualize it. If we progress down to the distal tibia and distal fibula, remember the medial malleolus is the distalmost part of the tibia. That's easily palpable on the medial side of the ankle. And then the lateral malleolus is part of the most distal part of the fibula. And again, that's easily palpable on the lateral side of the ankle. Those are the big round bulges that you see on either side of the ankle. Venous drainage from the lower limb or from the leg can be broken up into the superficial veins and the deep veins. The superficial veins are located superficially. They're in the subcutaneous tissue. The deep veins are located deeper. They run alongside the major arteries of the leg. The major superficial veins in the subcutaneous tissue include the great saphenous vein and the small saphenous vein. The great saphenous vein runs up the medial leg all the way from the foot up to the proximal leg, almost like the groin region. The great saphenous vein forms from the union of the dorsal digital vein of the great toe, so the big toe, which is located medially, and the dorsal venous arch of the foot. The great saphenous vein ascends or goes up anterior to the medial malleolus, so it wraps around in front of the medial malleolus of the tibia. And then as it goes up the medial side of the leg, it kind of goes towards the back a little bit and passes posterior to the medial condyle. It then goes deeper in the leg. It traverses or goes through the saphenous opening in the fascia lata. The fascia lata is the deep fascia of the leg or the thigh. So up until this point, in the thigh, the great saphenous vein has been located superficially, right, in the subcutaneous tissue. And then in the thigh, it goes deep. It goes through the saphenous opening in the fascia and then empties into the femoral vein. The small saphenous vein is located on the lateral side of the leg, and it forms from the union of the dorsal digital vein of the fifth toe, which is the pinky toe on the lateral side of the foot, and the dorsal venous arch of the foot. So these come together and form the small saphenous vein at the ankle region. The small saphenous vein goes up behind the lateral malleolus, which is part of the fibula. And then it goes up to about the midline of the fibula and then penetrates the deep fascia and ascends between the heads of the gastrocnemius. This is like the large calf muscle, which remember has two heads. So the back of the leg. So the small saphenous veins goes up between those two heads and then empties into the, sorry, there's a T there, empties into the popliteal vein at the back of the knee. Okay, so here you guys can see that the great saphenous vein is the larger of the two, hence being called great as opposed to small. But these are both superficial veins. The great saphenous vein is again on the medial side. So you see it forms from the dorsal venous arch, comes up the medial side of the leg, goes back behind the medial condyle. It penetrates the deep fascia, the deep fascia, and then flows into the femoral artery. which is like right here. The femoral, into the femoral vein. So into the femoral vein, same area. The femoral vein eventually is going to go up and drain into the external iliac vein, and then the common iliac vein, and then the inferior vena cava. The small saphenous vein you see on the lateral margin of the foot, right? And this is, we're looking at a posterior view of the leg here, but you can see it coming up the pinky side, right, the lateral side of the foot, and then it crosses to the back of the leg, right, goes up between the two heads of the gastrocnemius, right, there's one head, there's another head, and then it's going to run into or penetrate the deep fascia and flow into the popliteal vein. So back here at the back of the knee, we have the popliteal vein. And ultimately that will end up entering into the femoral vein. The deep veins of the leg, again, follow the major arteries and their branches. So the femoral vein, anterior tibial, posterior tibial, popliteal. When we look at the deep veins of the leg, they typically occur as pairs. So there's not just one anterior tibial vein or posterior tibial vein. There's pairs, or they're called accompanying veins, that flank the artery. So one on either side of the artery. Ultimately, everything drains into the femoral vein, and the femoral vein passes deep to the inguinal ligament, which, remember, stretches across the inguinal region to become the external iliac vein. And again, I just mentioned that the external iliac is going to become the common iliac, which becomes the inferior vena cava. Perforating veins are veins that penetrate the deep fascia and interconnect the superficial and deep veins. They have one-way valves present that allow the blood to flow from the superficial veins to the deep veins, but they prevent the blood from going backwards. Here you see venous drainage. We already looked at the great saphenous vein, which, remember, was the superficial vein out here. And the small saphenous vein we saw going up the lateral side and then posteriorly into the popliteal vein. Other major veins, the femoral vein, again, wraps around the femur just like the femoral artery. So it comes, when it passes into the leg, it wraps around to the back of the femur and is directly connected to the popliteal vein. And you can see that the popliteal vein splits and gives us the anterior and posterior tibial veins. So the anterior tibial vein is along the front of the tibia, and then over here the posterior tibial vein is along the back of the tibia. Also on the lateral side is the fibular vein. So you can see the fibular vein, the posterior tibial vein, and then the anterior tibial vein are all flowing into the popliteal vein. And the popliteal vein also accepts flow from the superficial small saphenous vein. And then the popliteal vein again flows up into the femoral vein. The femoral vein up in the inguinal area is going to accept flow from the great saphenous vein. And then that goes up under the inguinal ligament, right, which the inguinal ligament passes right there. And once it passes the inguinal ligament, it becomes the external iliac vein. When the external iliac merges with the internal iliac, it becomes the common iliac, and then again, the inferior vena cava. You guys should be familiar with the dermatome maps. So over here, the dermatome map for the leg shows you which spinal cord segment is responsible for which region of the leg. So you see, really, we're looking at lumbar and sacral spinal cord segments. The lumbar regions come down the anterior thigh, so L1, L2, L3, L4, L5, kind of coming in at the top medial portion of the leg, and then as it goes down, it radiates out laterally. And then the back of the leg is S1 laterally and S2 medially. Also over here, you guys should be familiar with the specific nerves that carry fibers to the different areas of the leg. Again, femoral nerve in the front, obturator nerve in the medial thigh, lateral cutaneous nerve of the thigh laterally, posterior cutaneous nerve of the thigh posteriorly. And then fibular nerve and tibial nerve in the lower leg, as well as the femoral nerve continuing down. Knowing the dermatomes and the sensory nerves that innervate different parts of the leg is important because we can do sensory testing on the limbs to find out information about the different spinal cord segments and nerves. The cutaneous nerves in the legs carry fibers from more than one segment of the spinal cord. They're multi-segmental. So we can use sensory testing to see where there's a loss of sensation, and that can help us to determine if there's damage to the spinal cord segment or spinal nerve, or if the damage is in the cutaneous nerve fiber. Pinprick test is utilized just to test for sensation in different regions of the limb, and then the areas that are lacking sensation are mapped out to see if they match a specific dermatome or if the areas lacking sensation spread between multiple dermatomes. If the area lacking sensation matches a dermatome pattern, if it's confined to just one single dermatome region, then that means there's damage to a spinal cord segment or spinal nerve, right? So like spinal nerve lesion. Because that spinal cord segment is sending fibers only to that one dermatome. If the area that's lacking sensation includes multiple dermatomes, then it's likely that there's cutaneous nerve damage, because again, the cutaneous nerve will carry fibers that go to multiple spinal cord segments, so they would include multiple dermatomes. Keep in mind that there is overlap between neighboring dermatomes. So there's kind of a gray area in between each of the dermatomes. So the area that's corresponding to a single spinal nerve lesion will actually be smaller than shown on the dermatome map. Okay, so if the loss of sensation is confined very specifically to the center of a dermatome region, then it's likely that there's a spinal nerve lesion or area to one spinal segment. Compartment syndrome can occur when there's increased pressure within a body compartment. Increased pressure within this confined space can compress the vessels that are present in that body compartment, and that threatens or interferes with circulation. Interfering with circulation then can cause tissue death and interferes with the function and viability of the tissue itself, as well as the tissue that's distal to the affected compartment. The fascial compartments in the lower limb are prone to compartment syndrome because they're closed spaces. The fascial compartments end at the joints above and below, so that the fascia is sealed off at the joint above the compartment and below the compartment. So they are complete closed spaces in the compartments of the leg, the muscle compartments in the lower limb. So trauma to muscles or vessels in the compartment can cause hemorrhaging and edema and inflammation that increases intracompartmental pressure or pressure in the compartment. This can occur because of things like burns, sustained intensive use of the muscles, or blunt trauma to the muscles. The increase in pressure, again, compresses small vessels that go to the muscles and nerves and interferes with blood flow to the muscles and nerves. This ischemia can possibly cause permanent damage to the tissues if the increase in pressure isn't relieved in order to restore blood flow. A fasciotomy is a procedure that we do when compartment syndrome is present. Increased intracompartmental pressure in compartment syndrome, again, interrupts blood flow. When compartment syndrome has interrupted blood flow, you will notice that there's a loss of distal leg pulses or weakened distal leg pulses. Again, because blood flow has been interrupted, you won't feel pulses distally in the leg, past or distal to the compression of the vessels. Also, a decreased temperature distal to the compression of the vessels. And lack of blood flow means that the temperature will cool. So again, a fasciotomy is what we perform in order to relieve the pressure in that compartment. An incision is made in the fascia to literally open it up, and that allows a relief of the pressure and restores blood flow. Here you can see the compartments that are present in both the upper and lower leg. Here in the upper leg, you see the anterior compartment with the muscles that are included, the medial compartment here in pink, and then the posterior compartment in purple. So, for example, the medial intermuscular septum comes along here, the lateral intermuscular septum comes along here, and those form some of the compartmental walls. And then again, there's fascial layers that surround each of the compartments. In the lower leg, there are 4 compartments. Here in the lower leg, you see that we have that anterior compartment, the lateral compartment, and then we have 2 posterior compartments. There's the deep posterior compartment and then the superficial posterior compartment. Here, this is just showing you the fasciotomy in compartment syndrome, and it's a pretty bloody, nasty procedure, but again, it's necessary to restore blood flow and prevent necrosis and tissue death. So you see incisions are just being made, and then from the incision point, they're accessing each of the different compartments in the leg to cut the fascia and allow the pressure to be relieved. So for example, here it's saying through the lateral incision, the fascia of the lateral and anterior compartments are opened, and then through the medial incision, the fascia of the superficial and deep posterior compartments are opened. So initial incisions are made on either side of the tibia, and then from each incision, you can access 2 of the compartments to relieve the pressure. So that's important to realize that there are 4 compartments in the lower leg and 3 compartments in the upper leg or the thigh. And it might be necessary to relieve pressure in all of those compartments. Saphenous nerve injury can occur. The saphenous nerve is a really large nerve of the leg that accompanies the great saphenous vein. Remember, the great saphenous vein is a superficial vein that travels all the way down the medial aspect of the leg. And you can see here with the saphenous nerve, the same type of distribution, right? It's traveling down the medial side of the leg, and it's very superficial, especially in comparison to some of the other nerves, just like the vessel was. Because of its position, the saphenous nerve is easily injured. It's frequently caught by ligature during closure of surgical wounds. Damage to the saphenous nerve results in pain, tingling, paresthesia. Paresthesia is just numbness. Along the medial border of the foot. And if you look over here, you can see in blue the area innervated by the saphenous nerve. So you can see that there would be tingling, paresthesia, right, numbness here along the medial border, which is innervated by the saphenous nerve. Yeah, again, it innervates medial side of the calf and foot. Varicose veins are veins that are enlarged. They're dilated, tortuous veins. So because of the fact that they're enlarged and dilated or tortuous, they have all of these like curves and turns and twists, their size and their structure interferes with the valve cusps that are present in the veins. So typically there are veins, right, there are valves that are present, and the valves are important for one, preventing backflow of blood, so that the blood, when the muscles contract, the blood gets pushed up, and then when they relax, it doesn't go back down, right? So every time the muscles in the leg contract, it helps to push the blood forward, and the valves prevent the blood from dropping backwards. Also, the valves help to break up the big column of blood in the legs. There's this whole huge length of blood, and if that column of blood is all connected, it's heavy, and it tends to push down and pool on the bottom. If there are valves, every so often, it breaks up that column. So there's just little tiny sections of weight, not that whole big column. So valves are important in the vessels of the leg. And if the vessels get dilated at all, or they have an odd shape, the cusps of the valve don't fit together well anymore. So they don't serve their purpose any longer. And that creates these varicose veins, which you see in this picture here. They're common in the veins of the posterior medial leg. The great saphenous vein is a very common site for varicose veins to develop. When the veins begin to get varicose, it's kind of a positive feedback cycle of worsening and worsening and worsening. The blood accumulates, and as it accumulates, it further dilates the vessels. That further decreases the competency of the valvular system. And again, the cycle just continues. A DVT is a deep vein thrombosis, right? So thrombosis is a clot. So a clot in a deep vein, typically the lower leg. This is characterized by swelling, warmth, erythema, and infection, possible infection in the leg, but always characterized by a red, swollen, warm leg. A DVT, or deep vein thrombosis, is typically caused or may be caused by venous stasis. So anything that stops venous return, it stops the flow of blood in the legs, and it anything that forces the blood to just kind of sit in the deep veins of the legs can cause or help cause a DVT, or a deep vein thrombosis. So things that might cause venous stasis. Incompetent loose fascia, right? So if the fascia doesn't compress the muscles to help with that musculovenous pump, I just told you guys that the muscles squeeze the veins, and that helps to pump the blood forward and keep it moving. If the fascia is just kind of a loose, lazy fascia, that decreases the effectiveness of the musculovenous pump, and the blood tends to sit and pool in the veins. Also, external pressure on the veins, so an external constant just squeezing of the veins, can cause venous stasis or impede the return of venous blood flow. This external pressure can occur from casts or bandages that are too tight, or constant compression. So like compression hose that are just constantly providing compression. Also, muscular inactivity. So prolonged muscular inactivity, prolonged just, sitting on a flight that's 10 hours long, can be associated with the development of a DVT. And again, just real quick on the last slide, I said compression. That's constant compression. The compression devices, SCDs, is a device that it provides compression and stops, compression and stops, compression and stops. Those actually prevent DVTs. So we put those on hospitalized patients, for example, because it mimics that musculoskeletal pump to keep the blood flowing. So don't confuse constant compression, right, with the compression device. The compression device actually prevents the DVT. Um, there are numerous lymph nodes in the inguinal region, which you can see here. Enlarged superficial inguinal lymph nodes are easily palpable because they are so close to the surface. The inguinal lymph nodes drain lymph from the entire legs and from the pelvis inferior to the umbilicus, as well as the perineum. So if the inguinal lymph nodes are enlarged and palpable, the entire area should be inspected for the cause of the enlarged palpable lymph nodes. In females, it's important to also consider the remote possibility of metastasis of cancer from the uterus, which is possible. Also, minor sepsis may also enlarge the inguinal lymph nodes. The patellar tendon reflex is a reflex arc that you'll test. To test the patellar tendon reflex, the patient sits with their legs just at rest, legs completely dangling down. So like sits on the table, the examination table, and the legs should be completely relaxed and dangling down at about a 90-degree angle with the knee flexed. A reflex hammer or some sort of tool is used to firmly strike the patellar tendon. The patellar tendon, it's also sometimes called the patellar ligament, goes from the patella down to the tibia, right? Specifically the tibial tuberosity. So it's this section here. Above the patella is the quadriceps tendon, right? Connects to the quads, the muscles of the anterior thigh. But the patellar tendon is below the patella. So remember, you can easily palpate the patella, and then just inferior to the midline, you'll feel a little bit of like softness below the patella. That's the patellar tendon. The reflex hammer is firmly and quickly used to tap the patellar tendon or patellar ligament, and this should cause the quadriceps muscle to contract. Okay, so pushing on that tendon will stretch the muscle, and that should reflexively cause the quadriceps muscle to contract to shorten that. When the quadriceps muscle contracts, the leg may extend, right? So the leg may kick out and extend. But putting a hand on the thigh will allow you to feel if there's any reflexive contraction at all. This tests the integrity of the femoral nerve, which innervates the quadriceps muscles, as well as the L2 through L4 spinal cord segments. The gracilis is one of the adductor muscles on the medial thigh, the inner thigh. So looking over here, this is the gracilis. You can also see the adductor longus. There's an adductor magnus there. Those are adductors, right? So they're used to pull the leg in towards the midline. The gracilis is, again, a relatively weak one of these muscles, and removal of the gracilis is not associated with a decrease in strength or function that's anything that actually matters, right, or affects function. So the gracilis can be removed without hurting the person's quality of life. And then the gracilis can be transplanted to replace a muscle that's been damaged in another area. So the muscle, innervating nerve, and vessels are all transplanted to replace other damaged muscles. The gracilis is frequently used to replace muscles of the forearm, and it can also be used, it can also be used to reform an external anal sphincter. A femoral hernia is a protrusion of the abdominal viscera. Typically, it's a loop of the small intestine that protrudes, but protrusion of some of the abdominal viscera through the femoral ring into the femoral canal. A femoral hernia is more common in women. Inguinal hernias are more common in men. So to remember that, just write the word femoral, right? Femoral hernias are more common in females. Okay, fem and fem. Inguinal hernias through the inguinal canal, again, are more common in men. You can see over here, part of the intestines protrudes right down here through this femoral canal. This over here is showing you a femoral hernia. Hey, notice the kind of orientation or the direction that it's going. The femoral canal is going out towards the leg, right? So it's directioned out laterally, okay, and inferior to the inguinal ligament. Look at the inguinal hernia. Right? The inguinal hernia is superior to the inguinal ligament, and it's protruding out towards the midline or medially. And this makes sense, right? The inguinal canal is where the testes pass through, and the testes don't descend out towards the legs. The testes descend in medially, right? The femoral artery and femoral vein don't go in medially, they're going into the legs. So they're passing out laterally. So if part of the intestines escape through the inguinal canal, that hernia is going to be located more medially, right, in the pelvic area. If part of the intestines are escaping out through the femoral canal, they're going to be going out towards the leg, more inferior and more lateral, which you see right here. This is a femoral hernia. And the inguinal ligament would be like right here. So you can see it's inferior and lateral to that. Initially, while the intestines are in the femoral canal, before they've actually opened out or exited out into the leg, these are relatively small hernias. However, it can exit via the saphenous opening, and then it's located in the medial thigh much more superficially. Okay, remember that the femoral canal opens via the saphenous opening, and that's where the great saphenous vein passes through, and the great saphenous vein travels down superficially, right, down the medial thigh. So if the hernia protrudes all the way out through that saphenous opening, then it'll be quite a bit larger and seen on the medial thigh. If this occurs and if the hernia enlarges, strangulation is possible. And strangulation, or think of like strangling, right? It strangles off the blood supply or interferes with the blood supply to the intestine that's been herniated through, which causes tissue death. And this is a big deal. It needs to be surgically repaired. The femoral pulse is a strong pulse that's easy to palpate. The femoral pulse is palpable just right at the very beginning of the femoral artery. So it's just inferior to the midpoint along the inguinal ligament. Remember, the inguinal ligament stretches in across, like by the inguinal crease, right, between the pelvis and the leg. So the inguinal ligament stretches across that region. If you find the midpoint of the inguinal ligament and go just inferior to that and push in, palpate kind of deeply, you'll be able to feel a strong femoral pulse. A diminished femoral pulse can be due to occlusion or blocking of either the common iliac artery or the external iliac artery. The femoral artery can be compressed in this area to control bleeding in a distal vessel. And the femoral artery is commonly cannulated at this pulse point. So right near the point of the origin of the femoral artery, just inferior to the inguinal ligament. We frequently use the femoral artery to insert catheter. And this can be used, for example, for like left cardiac angiography. The catheter is inserted into the femoral artery and it's threaded up eventually to the aorta, and then all the way up to the openings of the coronary arteries. Again, the femoral artery is used frequently because of its size. So for cardioangiography, for cardiopulmonary bypass, we can utilize the femoral artery as an entry point for the catheter. note that this was left-sided here. If we're doing right-sided cardiac angiography, then the catheter would be inserted into the cardiac vein. The cardiac vein is located just medial to, I said cardiac vein, femoral vein. The femoral vein is utilized for right-sided cardiac angiography. And so the femoral vein is for right-sided. The femoral vein is located in the same area, just slightly medial to the femoral artery. And again, this makes sense, right? The artery, if you trace back the artery, that's going to go to the left side of the heart. The left side pumps blood out to the body. If you trace up the veins are going to go to the right side, right? The veins bring blood back and dump it into the right side of the heart. So if you want to get to the left side, you go up through the artery. If you want to get to the right side, you go up through the vein. Finally, we'll talk about the sciatic nerve. The sciatic nerve, remember, is a really large nerve that passes down through the gluteal region and into the thigh. Pain in the buttocks can result from compression or damage of the sciatic nerve. Sciatic nerve damage typically results in this characteristic kind of shooting pain or electric pain down the buttocks and the posterior thigh. Damage to the sciatic nerve can result in paralysis of the hamstring muscles, which would lead to impaired extension of the thigh and leg flexion at the knee. Piriformis syndrome involves compression of the sciatic nerve by the piriformis muscle, which you can see piriformis right here. And then you can see the sciatic nerve passing just under that. Any procedures or injections in the gluteal region should be done keeping in mind the passage of the sciatic nerve to make sure that the sciatic nerve is avoided. Injections into the gluteal region are typically done in what we call the lateral safe zone. The lateral safe zone is the superolateral quadrant of the buttocks or the gluteal region. So here you see in green is the safe zone, right, or the zone that it's fine to give an injection into without having to be concerned about hitting the sciatic nerve.